It's a shame that we still have people dying with malaria. Pregnant women will also get malaria, and we need to try to treat the pregnant women. As a clinical pharmacologist, there is a specific area of pharmacology that is pharmacovigilance. It's where I dedicate most of my time. Most of the time people think that pharmacovigilance is to remove drugs for the market because they are not safe. But we want to understand what the drug do in our body and what our body do to the drug or the vaccine. Access to medicine, it's my priority as a clinical pharmacologist. In Mozambique, we are only 3 clinical pharmacologists. My first fellowship with the EDCTP was a career development fellowship in 2006. In 2007, the prevalence of malaria was really high, 52% all over the country. Quinine was the drug that was used in pregnant women. When we moved to a new anti-malarial drugs, artemether, lumefantrine, there was alert of risk of congenital defects, and that removed the pregnant woman to benefit from this drug. But using a complex methodology, we managed to conclude that the use of artemether, lumefantrine was better than quinine in pregnancy. That allowed the WHO to recommend the use of artemether, lumefantrine in pregnancy. Grants allow me to share my experience with others. I'm still optimistic, but we can't do it alone. There's still more to do, but we have to be persistent, to believe, and also to make sure that you listen to others. We need the involvement of everybody to make sure that we manage to get the best drug to the best people at the moment that they need.
Starring my good friend Esperanza. Congratulations, thank you. It's my pleasure and my honor to welcome all of you this afternoon to this plenary session on prevention of severe complications of pregnancy and early life. The interaction between infectious and non-communicable diseases. And I'm so happy that we have a plenary session on the very important women and children topic, very important for EDCTP as well. I'm co-chairing this session. My name is Marlene Temmerman, and I'm co-chairing this session together with Lara Pandya. Lara, who are you? Tell us a little bit. Who is Lara?
Well, I'm a Senior Strategic Partnerships Officer at EDCTP. I've been there since, well, on and off since 2007. I used to be a project officer. I went away for a while to study a master's in public health. My social science background comes in there. And then I came back as a networking officer in what's now become strategic partnerships. Yeah.
Thanks, Lara. And you are also going to tell us a little bit about while we are here.
Why we're here. Yeah. Let me just pull up one slide. So the subject of today's plenary on maternal morbidity and mortality is especially poignant because it's in honor of our dear late colleague and friend, Ana Lúcia Cardoso Weinberg, who tragically passed away on the 3rd of October, 2022. I would like to extend a warm welcome to members of Ana Lúcia's family who are joining us virtually today. we are all missing her warm smile and vibrant personality at this year's forum. Ana Lúcia was a senior strategic partnerships officer, like myself, at EDCTP. We were teammates. And she's remembered by many of us as a bright, passionate, and motivated person who was fully committed to building and fostering invaluable and sustainable partnerships for global health research. She was dedicated to capacity building in Africa, and among many other things, she was instrumental in increasing EDCTP's involvement in Portuguese-speaking African countries. Ana Lúcia's untimely passing followed an almost year-long battle against heart problems caused by spontaneous coronary artery dissection, or SCAD. As you may know, SCAD is an emergency and a rare cardiovascular condition that happens suddenly with no apparent warning. Unfortunately, not a lot is known about this condition or its causes. One of the few things we do know is that at least 80% of people with SCAD are women, and it can often occur during or soon after pregnancy, as was the case for Ana Lúcia. Further research is needed to help us better understand such rare but fatal conditions. Prior to her death, Ana Lúcia had been discussing her case with experts and was keen to get involved in raising awareness about SCAD and advocating for increased research funding. We would like to honor that motivation today with a memorial lecture and a panel discussion focused on maternal mortality in sub-Saharan Africa, looking at infectious and non-infectious contributing causes, the future research agenda, and what role EDCTP could play in this space. Before Marlene introduces our keynote speaker, I take this opportunity to thank the Portuguese Foundation for Science and Technology, the Carlos Gulbenkian Foundation, and La Caixa Foundation for their generous support of the Ana Lúcia Cardoso Weinberg and Ricardo Pereira scholarships that are supporting investigators from Portugal and Portuguese-speaking African countries to attend and present at this forum. Over to you.
Thank you. Thank you, Lara. You did very well. I remember we were there in the one of the meetings, SAC meeting in 2022, when this tragedy happened, and I think the whole team and everyone around was really shaken indeed. So I think maybe I introduce myself just very briefly. As I said, I'm an obstetrician gynecologist, Belgian origin, but having worked many, many years in African countries, mainly in Kenya, where I'm based now, working with the Aga Khan University. And I think the research work started, I see many, many friends here in the 80s when we were working on HIV and the impact on pregnancy and many, many other things, Save Motherhood, moved in that direction. I'm also very happy to say that I was with EDCTP since the very early days. And then EDCTP2 as a member of the SAC, and now in the Global Health EDCTP3, also as a member of the Scientific Committee. So,
but don't forget, you're also an EDCTP prize winner now, Marlene.
Oh, yes, thank you. Thanks for reminding. Lusaka 2016, I got the award for the female researcher. Thank you, EDCTP. That was really great. But I'm happy now to introduce my good friend and colleague, Professor Claudia Hansen. Claudia is a German OBGYN who moved a long time ago to Tanzania to do field work, met her husband, Swedish, followed him like a good wife to Sweden, right? Where she became a professor in Karolinska Institute. Implementation Science is her middle name. She is also working for the London School. And recently she decided to come back to East Africa and to join the Center of Excellence in Women and Child Health that I'm leading now together with Claudia at the Aga Khan University. Claudia, the floor is yours. A long title, very interesting topic. Over to you.
Thank you very much. Thank you very much for the kind introduction, and I think I have nothing really to add here. So, this memorial lecture is somehow really about life. And I got this title, which I think is really more than a mouthful: Preventing Maternal Death, Care and Prevention of Severe Complications of Pregnancy, Early Life, and then the interaction, infectious and non-communicable diseases. It's somehow everything except accidents. So I tried to make something out of this. So I was thinking, so what is it and how is the link really to EDCTP? So I will give you an update on maternal and perinatal mortality. Then I take a bit a life course approach, go to adolescent complications in pregnancy, and then a bit on the interactions between maternal health and infectious diseases. And then my last slide will be a bit about the health system challenges, which I, as an implementation science researcher, just do want to remind us. So there's a staggering number of annual deaths. So we have been hearing about the success actually for HIV and malaria. So the maternal health community managed to get down from 500,000 to 300,000 maternal deaths. But this is still, like the old saying, it's somehow 3 jumbo jets still crashing every day. In addition, 2 million stillbirths, so they only came very recently on the international agenda. And they are not part of the SDG targets. 2 million neonatal deaths, so a total of 7 million children, adolescents, and youth dying. So if you sum this together, you can do it in different ways, but it's a huge amount of deaths still around pregnancy, childbirth, and early childhood. So this is the map of maternal mortality. And there are countries which still have a maternal mortality ratio of 1,000 per 100,000 live births. So like really a lot of years back, we don't have it all over Africa again, anymore, but there are still countries like Niger, Nigeria, and war-torn countries, and also Afghanistan, who really have these very high rates of death. And this means for a young girl who is born and it's 14, 15, that she has a lifetime risk of dying from maternal causes of 30. So, and this does have become increasingly actually a problem, not an African problem, but a large part. So almost 3/4 of these deaths take care in Africa. And this is also because a large part of the births take care in Africa. At the moment, it's something like 25, a bit more than 25%. But in some 20, 30 years, it will be more than a third of all global births who will take place in Africa. So then stillbirth, as I said, it is now to some extent on the international agenda. It shows a very similar picture to the deaths of maternal mortality, so centered around Africa, Afghanistan, Pakistan. But what I want to emphasize is, so while we have done quite good progress during the Millennium Development Goal period, the progress has really stalled. Yeah, so there is no chance actually to meet the goals which have been set of having all countries below 12 per 1,000 births, so a death rate below 12 per 1,000 births. So it's a total of almost 60 countries in Africa Africa and Asia, who will not meet this goal unless really a lot of efforts are done. Then it's not only about deaths. So we continue to have a large amount of preterm births, and they are connected to some extent to infectious diseases, but also to many other reasons. And again, so we see sub-Saharan Africa and Southeast Asia being very important settings here. And the same is for low birth weight. A baby who is born too early or with low birth weight has many more issues for thriving actually healthy later in life. So it's not a good start if you are born too early or with low birth weight. And here you see there's not much progress which have been done throughout many, many years. So different from somehow infectious diseases, maternal newborn pregnancy care, they are much more concerned about many continua of care. So it's not one drug which can really do the difference. So the road to death is here often very multifactorial, which makes it much more difficult actually to say what can make a difference. So it starts with low education, little money, all the social demographic determinants. Then it goes to the women, so they have still many children. There's still anemia. I like to remind that Taj Mahal has been built for a woman who died of postpartum bleeding, probably because she was also anemic. We don't know this, but she had been given birth to many children before. So then we go the path. So the woman goes to antenatal care, limited services, too few skilled health providers, and then she wants to go for delivery care in the hospital, distance, travel cost, user fees, too little skills, too little drugs, and maybe no blood transfusion available. So that's the many health system issues we are facing as a maternal and newborn health community. Now to the medical causes of death. So a quarter is dying because of severe bleeding. This the same reason why the woman for whom Taj Mahal has been built has been dying. So this death can appear in some 2 hours, 3 hours a day. So some women bleed 1,000 liters. So it's not difficult to recognize that you really need immediate, really very good care. So then there are a few other diseases, hypertensive disorders, infection, abortion complications, and then there's also the 1 quarter where we say it's about pre-existing conditions like obesity, diabetes, but also malaria and HIV. So this links back to the video, what we have been seeing before. But it's also to recognize these data are old. The last review was from 2014 because there's no money to do a new one. So there's also a little bit of changing landscape. So with development, we get rid of some of the hemorrhage deaths, but the maternal community then sees more indirect deaths, obesity, diabetes, and so on. So there's a little bit of changing landscape, and we also know these are some slides from the latest Lancet series, that also the whole place where births are taking place is changing. So we have to address now more and more also the urban challenge, which are quite different from the rural challenge, but still mortality rates are high. So there has been in the last year quite a lot of papers which show that actually now neonatal mortality is higher in urban places than in rural places. So that is important to recognize and important also to address, and much more research is actually needed because we don't know why. So, and now a bit the life course approach. So I made this complicated slide. I'm very sorry about it, but this is a little bit, so that's life, yeah? So we move from birth to older age. As an obstetrician, I'm very much aware about the classical risk factors. So first bleeding, first birth, ages at menopause. We have now talked a lot also about in expanded risk factors, which is very important for really healthy driving. We know it's important to be born, not as a preterm, not low birth weight, not being asphyxiated, so not with a low APGAR score, also not with malformation. So to have a healthy thriving, you need the breastfeeding, but you also in later life, you need security, prevention from accidents, healthy lifestyle, and so on. And this all takes place somehow in a complex environment. We know about the socioeconomic and political context. Individual socio-demographic factors play a role. access to quality care, genetic factors, environmental factors. And we have been explaining, for example, just as one factor, breast cancer. We know if a woman breastfeeds, it's a bit protective. A healthy lifestyle is protective. Genetic factors can be protective or just the opposite. And then it's about access to health care. So this is what it is if we want to take it all together. And then we know an adolescent girl, and we have been hearing this morning, they are much more likely to get HIV infected than actually the boys. Yeah? But then we have not only the risk of HIV, we also have the risk of early pregnancy. And this, we have been talking a lot, okay, it's a risk factor for death, but it's also social rejection, lower education, lower economic status, but then actually it expands throughout life, what we see now. So there's an increased risk of probably of cardiovascular diseases and also physical performance in later life. So it needs to be addressed much more in a comprehensive way. So then also some examples of where really pregnancy care and non-communicable diseases link up. So we have this disease complex, so-called hypertensive disorders, where the women get high blood pressure and then maybe even fit later on. So if you have such a disease during pregnancy, yeah, which affects almost 10% of pregnancies, you have a twofold, threefold higher risk of non-communicable diseases in later life. And similar, diabetes. So if you have a diabetes during pregnancy, and again, this affects quite a large number in some settings of women, you have a much higher risk of later also to develop a type 2 diabetes and even a type 1 diabetes. Yeah? So we have opportunities, we know these risk factors, but we have not taken them on board, for example, of explaining the women and giving them long-term support. But the evidence is really increasing about all these connections. And then we have all this imprinting theory, also a woman who is already born as a child with low birth weight is much more likely to develop hypertensive disorder, and then she is more likely to give birth to a baby, which is then again low birth weight. So we have a lot of virtuous cycles which we need to break through. So now a little bit more about perinatal health and infectious diseases. So I showed the slide on maternal mortality already, so we have this maybe 10% of global maternal mortality, which is much related also to infections, and we have much more actually which are related to infections if you look at the perinatal mortality. So the neonatal death, there's quite a morbidity which is fueled actually by infections. We have the sepsis, and we also have these fantastic success stories of tetanus. So there's quite a lot of interlinkage. So, and in the video we saw talking about malaria and pregnancy. And I would like to thank probably this audience and many more. This has become rare. So this has become much less seen. So what has been there in the old times was saying that actually almost a third in some countries, third of maternal deaths were due to HIV and due to malaria. This is not the case anymore. So, and these are also again a bit old evidence, so which was saying so there's a 8 times increased risk if a woman is HIV positive to die a maternal death in this, and this means that 20 to 30% of the deaths were due to HIV in the old times. So you don't see much of this anymore. At least this is what I hear. Again, we don't have a review. Yeah. So, and then that time they were also thinking through, so is it really, for what is it a risk factor? So it's a little bit a risk factor, HIV still for sepsis, but not for postpartum bleeding. So the maternal mortality sits on the postpartum bleeding. So we know COVID infection was a risk factor for the women. It has not been super clear to which extent it's a risk factor for stillbirth or neonatal death. But anyhow, I think we are almost really over, and it was good that then also the vaccination went relatively fast, also with delays, with certain problems, but that the recommendation came out during these waves. So now two slides actually on maternal immunization, which is an opportunity. Yeah, an opportunity what pregnancy care offers, but also an opportunity actually to link several things really up. And I just want to say it's a fantastic, and we should celebrate this much more, how much actually tetanus prevention really worked through protection of the mother, but also through the antibodies to the baby. So then we sit at the moment of still quite a high burden on beta streptococcus. And this is a very old thing. So I copied here in now an old slide from sepsis 150 years back. And it's clear when the antibiotics became available, so the number went really down. It never went down to zero, but it also shows that if you have new possibilities, it really does something. But it's still that there are deaths and disabilities and complications, particularly for the newborn, and there are still women also dying. So here, a vaccination against beta streptococcus really can do a difference. And there are a few more vaccines available, beta streptococcus, but also the AS virus. So this is very welcome to really reduce the total burden on perinatal deaths in this area. So, and now I just want, and please bear with me, some of the slides are not easy really to manage. This all takes place in health systems. And this is an example of toilets in the labor wards. Yeah, so there is a lot of actually really disrespectful care, a lot of things which we haven't managed. Yeah, we have these babies who are stillborn and just put at the side without dignity in the middle of all the cleaning materials. Yeah, so we have labor wards who are looking like this, and the maternal health community have been showing there's a lot of disrespect, shouting, slapping, overburdened healthcare workers who are not giving respectful care. So, and then also having worked in the space since a long time, we have not always really done good integrated care. So again, this slide is a bit old, it's 10 years old, but it shows that actually if you take the blood of the mother, yeah, so it is much more likely that it's tested for HIV than it was tested for syphilis or for hemoglobin to see whether the woman is anemic. So for me, I've been always saying this is a violation of rights. Yeah, so we have the possibility to test for anemia, we have the possibility to test for syphilis, and I know these are older slides. It has moved, and I like to say thank you that it moved, but to some extent it was the battle for resources which were not always super helpful. So I would like to I hope that we have a discussion, that we have a little bit more a road to death, that we join forces, that we really do things in a concerted way. I show here a nice labor ward from Malawi where actually so what happened during the COVID period is that the German corporation said we have to do something and build actually extra cubicles. So here now you can do much more respectful care with the companions. So this looked completely different, these labor wards. And also there has been improvement. We see it from the demographic and health service with integrated care. So as you see, things are joining up. So I think we can do differently, and I hope that we also can do differently in research to outline really a pathway to respectful, high quality, integrated, and also resilient care. Thank you.
Thank you very much, Dr. Hansen, for an excellent presentation, showing us the wide range of issues and everything that still needs to be tackled in this area. We do have a few minutes for questions, just a couple of minutes. I don't know if anybody has anything that they would like to raise. I'm trying to see. Oh, I see someone coming up here in the middle. If you could please briefly state your name and where you're from.
Thank you very much. I'm Gerard Mutunji from Uganda, Ministry of Health. Thank you for the excellent presentation. You mentioned that pregnant mothers who have hypertensive disorders or diabetes are more likely to have non-communicable diseases. I wanted clarification. Were you meaning the unborn babies or the mothers themselves, or both? Thank you.
So it's the mother. So that's what has been investigated.
I see someone's getting up here. We'll wait for you to get to this microphone.
I have a question regarding the disrespect in the birthplaces, because my wife is a midwife in the Philippines and she observed the same. But it's for me a bit of a mystery because it's almost a holy moment, a beautiful moment, and why would we not be able to interact as decent human beings? What's behind this?
I think that the nurses and midwives are to some extent partly exploited, disempowered, little seen community, and they act like this. So sometimes not paid. In my WESA supervision, where are the midwives really being part of research, really research? It's not that there's nothing, yeah, but there was just also a paper published on summarizing the money on research for stillbirths. Yeah? 2 million, yeah? 2 million stillbirths. I don't have now the number in my head, what it was, just unbelievable little money, yeah? So, and I think it would be nice actually if the nurses and the midwives do the research more or less themselves to actually help them themselves really to understand what is actually happening in the labor ward. So I can't blame them actually. So I think it's a much more broader thing, and we should also not forget labor care was also not respectful when my mother gave birth to me. Yeah, so it's not an African or Asian problem. Yeah, I really want to say this. It has been very clear also from the reports from my mother.
Thank you. There are two more here, and I think these will probably be the last two questions, if you could make them quick. Thank you.
All right, good evening. Thank you. My name is Noble Father from Nigeria. Thank you for the wonderful presentation, and listening to you resonated with a study I just did that was supported by EDCTP 2. And I can see truly that we're having serious problem of malaria in pregnancy, and then having other complications. And then also, as you mentioned, the antenatal care. From my study, we discovered that women that came into the tertiary institution had a better care, and we could pick up the adverse drug reaction than those that went to the local antenatal care services. And I was wondering, could there be a program to improve maybe training in those local listings, because some women still prefer to go to the traditional birth attendants, to the local facilities, while there can be a focus funding to train them in order to curb this. Seemingly, in some countries it's stagnant, but in Nigeria it's rising, and we have a very high rate of young women that are getting pregnant. Thank you.
Sure. Training is one part, but seeing really this EDCTP consortium let us make midwives and nurses do the research what is needed together with the women. What do they want? Yeah? How should healthcare systems look like?
Sorry, we just have time for one last one, and if you don't mind keeping it very quick, that would be great. Thank you.
Thank you very much. My name is Yoba Saido. I work for Clinton Health Access Initiative. So I think maternal health is really one of the things that is under my portfolio. So I really get frustrated each time I listen to academic presentations like this, because we are good at studying the problems, but we are not so good at really telling governments and donors what exactly to do. And I think there is that need of really shifting the paradigm, because there are a number of organizations that are set up to actually address these problems. You have organizations like UNFPA, Global Financing Facility, UN Women, and even bilateral organizations like Islamic Development Bank and all the other the bilateral organizations that you could think of. How could we really galvanize? How could we really galvanize these organizations to invest into health system strengthening aspects that could address this maternal mortality? I think there are a lot of resources that those organizations have that we can harness, and I think we really need to figure out a way of engaging those organizations so that they direct their resources to things that actually matter. Thank you.
No, thank you. I agree, but if you have if you have little rain, the seeds will not grow. Yeah, so you need enough money, so enough rain, yeah, to use this algorithm. And I know how many people are trying to do good, but I think we need a certain threshold that in these settings people can take over to really transform. Yeah, and we don't have the threshold funding.
Thank you so much. Thank you very much for an inspiring lecture, and I think that proves an excellent basis for our panel discussion.
Thank you so much, Dr. Hansen. I think we could continue a whole conference actually only on this topic. Now it's time for a panel, and I'm calling the panel members to join me here on stage. Before we go to that topic, I just would like to say that the publication that Claudia was referring to about the money that is allocated for stillbirth research, number 4 on the list is EDCTP. I read the publication, and they were all calling yesterday and saying, you know, you're at EDCTP. Thank them, even if it is not big money, 42 million over 10 years, but it's it's number 4 donor in the research on stillbirth. So we could also mention that. So now over to our panel. We have only one mic, so I'm going to stand here. And it's my pleasure to introduce the panel members. Actually, we were 4, but Dr. Dosu from Benin didn't manage to get a visa, so he could not join us. And first Esperanza, but I don't think Esperanza needs a lot of introduction because we have seen the movie, the video. She is joined by Professor Philippe van de Perre. Philippe, can you introduce yourself, please?
Yes, thank you. So my name is Philippe van de Perre. I'm a professor of medicine and virology at the University of Montpellier in south of France. And I'm working also in a very nice research unit supported by INSERM in France, which deals with chronic and emerging infections, which is coordinated and led by Nicolas Nago in Montpellier. I can hear some of you telling me what a male virologist has to do with maternal mortality. In fact, in the last 40 years, I've been obsessively working on transmission from mother to child of different viruses, at the beginning with HIV and the link with the infant feeding, which is directly linked with the question of today.
Yes, good afternoon, everyone. I'm Barbara Kerstiens. I work in DG Research and Innovation of the European Commission. I'm a medical doctor and a public health specialist, and maternal health and newborn health is close to my heart, certainly after working 2.5 years in a hospital in Chad in the middle of nowhere. So I know what, at 3 o'clock in the morning, when there's a knock on your door, you know, oh, there's a problem. And it's likely to be a pregnant woman who hasn't been in labor for more than 2 days, and you hope that you try and save her, if not her child. Thank you.
Thanks, Philippe and Barbara. So my first question to the panel members actually is, in your opinion, considering the interaction between, you know, of the double burden of infectious and non-communicable diseases, what are the major challenges you are facing, Esperanza, like in a country like Mozambique, and what can we better do to prevent maternal complications and death?
Thank you, Marlene, and thank you for the other members of this panel for the opportunity to be here. I will start saying that malaria, HIV, and tuberculosis is still a challenge in most African countries, and pregnant women still at risk, and we have examples of real critical situations that we have very high prevalence of this disease. For example, we are now running a Pirapreg trial that is for testing a new anti-malaria in pregnancy. And we have 5 countries involved in this study. And 3 of them has a real quick recruitment rate. That means that they still have high prevalence of malaria. And this high recruitment rate was different among the countries. Some countries are having this reduction of numbers, and the crisis still, it's look like the crisis is going, but we still have countries in Africa with high prevalence of malaria, and that can complicate pregnancy. HIV, I will take the example of Mozambique, my country, where the national rates are 12%, but for young adolescent and young women, the rate is double in all the country. But we have areas like Manisa Health Research Center, where I'm working, where we have rates above 30%. That means that 1 out of the 4 women that we see in the clinic has an HIV. And the HIV complicates any other disease or problem that the woman has. For example, we had other studies in this area. We call it CLIP trial, where we found that the prevalence of hypertension was around 11%. And this study was done between 2015 to 2007, 2015 to 2017. And the last study that we have was precise study in the same area. The prevalence of hypertension was raised for 19% in the population that we are working with. And this was also similar in other African countries that were involved in this trial. For example, the Gambia has a rate of hypertension 29%, and also Kenya had 70% of hypertension. That means that we are having malaria, HIV, tuberculosis in a context that we have also non-communicable disease, but also in a context that we have also other challenges. Claudia has shown some of health system challenges that I also have here. But what I want to share with you is that most of the deaths that we have in the CLIP trial that I referred before were within the health facility, not at the house, not at the road, but within the health facility. This is something that we should start thinking on. What we are doing, why we are not delivering the care that these women need. And the impact of And the impact of other conditions, like we had emergency conditions like COVID, the climate change. In Mozambique, we have rounds of cyclones that put pregnant women at risk. And also we have conflicts that also impact pregnant women. I think this is the context that we are talking on the resilience of pregnancy.
Thank you, Esperanza. Thank you so much for sharing, Philippe, your contribution, your ideas.
Thank you very much, Esperanza. For my part, I think one of the exercise that we should do collectively is to have a kind of a collective introspection on what we are doing properly and what are the real gaps, what needs to be done to completely tackle maternal mortality and mortality in the early ages. I think there are some gaps that are reflecting complete chapters that are completely neglected. And I would like to give just one example, which in my view is quite illustrative. And this example is tuberculosis during pregnancy, postpartum, and during the early age. As you know, approximately 28% of maternal mortality is caused by non-obstetrical causes. And among this group of non-obstetrical causes, the number one killer is tuberculosis. And that is completely neglected. Tuberculosis is responsible for, according to the different study settings, from 16 to 34% of those maternal deaths due to non-obstetrical causes. It is estimated that a pregnant woman with tuberculosis has a four-fold risk of dying as compared with a non-tuberculosis woman. This condition has also major consequences on the outcomes of the pregnancy, but has also enormous consequences in neonatal and early infant mortality. It is expected, as most frequently active tuberculosis is developing at the end of the late stage of pregnancy and in the postpartum period, that approximately 15% of those women with active tuberculosis will transmit the MTB to their baby, and that this tuberculosis disease in very early age is extremely difficult to diagnose, is completely neglected, and is associated with a 50% mortality. So I think really we have an opportunity with this tuberculosis during pregnancy and postpartum to, if we could control it, to hit two birds with a single stone, tackling not only maternal mortality but also neonatal and early infancy mortality. So why isn't is there so few fully integrated and well-organized program to tackle tuberculosis during antenatal and postnatal care? I think that many think that we have no perfect diagnostic tools for diagnosing and further treating TB during pregnancy. But my conviction is that within this imperfection of diagnostic tools, we should do what we can do with existing tools, because the impact of this is so major that this really deserve attention and integrated actions to tackle tuberculosis. That was just an example, but I think this is the kind of introspection that we need to do with the different aspects, the multiple aspects, as Claudia very nicely showed, of what is done and what remains to be done to tackle maternal mortality. And
thanks, Philippe. I think that's a very important topic indeed, because when we looked at literature, there are not that many data on tuberculosis in pregnancy. They are, but not in relation to mortality. And I think we don't do screenings, at least not in the areas where I work, for tuberculosis. And even if there is screening done, then the whole treatment. So maybe that is some of the topics that EDCTP could also kind of pay attention to. So Barbara, you are from the EU, right? EDCTP is the program on infectious diseases. But, you know, we moved from HIV, malaria, tuberculosis, then EDCTP2 was expanded. Now we are in global health. So can you reflect a little bit on global health, maternal health, infections, EU programs?
Yes, I think, and thank you for that question, Marlene. EDCTP was set up to tackle the burden posed by, indeed, infectious diseases for population, among others, in sub-Saharan Africa. But we also want to take care of vulnerable groups. And we can say that pregnant women and neonates are a particular vulnerable group. And in addressing the challenges of preventing maternal deaths and neonatal deaths, one is the complexity of the interface between infectious and chronic diseases. Hypertension and HIV both will influence the health of the woman during her pregnancy. And I think this is one of the areas that under the Global Health EDCTP joint undertaking might be tackled to avoid, like several of the panelists and Claudia herself mentioned, we need to not work in silos per discipline, because we will not get there to find a solution. And the second challenge is the fact that we need more innovative treatments, diagnostic tools that not only need to be developed, but also usable in the settings where they will be used. And that points to the point that Claudia made as well, the importance of implementation research. So we need to be more innovative on the one hand, being able to conceive the solution in the context in which it will be used, and implementation research can find or pave the way for the uptake in health systems. And I think EDCTP2 has been doing so, and I think this should be continued not only at the level of EDCTP, but under Horizon Europe funding as well. But I wanted to make another point, and that's my third point on the challenges, is the fact that we probably insufficiently reach out to women, pregnant or not, to be part of the research, involve them in the research. So if you leave pregnant women out of the equation of the research, what assurance will you have that what you actually will find is usable and effective for that particular woman? So I think EDCTP has done a great job in highlighting the fact that it is important to include pregnant women in the research. And at EU level, the same thing. We are now providing guidelines for how to safely include pregnant women in research, because this is really a piece of evidence that is missing, and it's important because we know that there's a difference, and all kinds of differences between men and women, but certainly the way, let's say, medicines are metabolized, etc. I'll leave Esperanza to talk as a pharmacologist, but these are my points.
Thank you, Barbara. And I think your last point has been shown again with COVID. Pregnant women, no vaccines. Pregnant women were not considered at risk initially, and so that had changed, but it took time. We had prepared 2 questions for each panel member, but time is not on our side, so I'm going to ask a very, very brief one to each of you. So, Esperanza, we talked about pregnant women, but there are other infections also important for women. What would be your number one? intervention or research recommendations?
No, I think EDCTP could also look to prevention tools for adolescent and young women, and looking not only to malaria, HIV, that was what we are constantly seeing, but also see other diseases that can be linked to infections, like cervical cancer, for example, HPV.
So HPV would be one of your priorities.
Yes,
Thank you.
I think.
Philip, we don't have much time, and I want to give 5 minutes to the audience. Philip, any priority suggestion? You said already TB, but maybe.
Yes, but I think one of the things that we have learned from the past is that the most innovative approaches are generated at the interface of different chapters of health. And here I think one thing that is really important is the interface between non-communicable and communicable diseases. And I think this, for example, may be a very nice opportunity for EDCTP to do more on that without revolutionizing the strategy of the institution, which in my view is absolutely excellent, but to really link the interface of those two major aspects of the question of maternal mortality.
Thank you, Barbara. Maybe also a word on other programs within.
Yes, I think the important part is not to forget women and children when prioritizing the funding. And as I mentioned, EDCTP has done so and should continue to do so. But also under Horizon Europe, we're funding, for example, implementation research on maternal health. And I think one of the beauties is of collaborative research, certainly if it takes place in different countries, you can learn from each other country-wise, and it's probably a very effective way to come to new evidence that can be then picked up by the systems in different countries. So I would simply say continue to think about pregnant women and their children, and let's say include them in the research, reach out to them, because they also will be able to voice what kind of needs they need to be addressed. And I think that is what we've been learning so far.
Thank you so much. I also think we could give a little bit more attention in the future to vaccine trials and immunization in pregnancy and for pregnant women, because there are a lot of new opportunities coming. So maybe we could, within this EDCTP community also think, how can we strengthen that work, bringing in also the women in as partners in the research. So thanks for the time being. You are not done yet, because now we have a few minutes, like 10 minutes, to interact with the audience and to invite questions. Who wants to start? We can maybe get some light. No questions? There are, I'm sure there are. Take your time.
Okay, hello. My name is Beate Kampmann. I work at the MRC unit in the Gambia and in the Charité Center for Global Health. Thank you for bringing up this topic, because it's obviously also a really important health systems topic. And I really wonder how we're going to bring together the siloed thinking around the disease entities with the structural changes we have to have in the way that we deliver care in the antenatal and postnatal section. My insights into this are very much sort of influenced by what we see in clinical trials. I do immunization trials in pregnant women. The mortality in our trials is so much lower, and that's not just because we are picking, women who are not as high risk, but because we have more staff. And I think the elephant in the room really is that the healthcare worker capacity in the countries is not at the level where we need it to be to even implement all the good ideas that are coming off the research. And I think the interactions with the you want a question, you don't want a story here, but I think the interactions with the governmental sides in which we are trying to bring these innovations are absolutely crucial. And maybe when we're going forward, are you considering that maybe in other trials or other suggestions that the governmental engagement in these applications should be one of the criteria in which funding is awarded? So that's my question.
Thank you, Marlene. No, I think one of my suggestions, as Marlene only asking me to tell one, this is the second suggestion that I have, was to have more implementation science. Because what we are seeing is that for some, we have already the tools, but the government don't see an impact of these tools if we don't convince them that they have impact. And the implementation science could help us to convince the governments that doing this is better to not doing, and it costs less to the government. And I think EDCTP could also engage on implementation science, bring the health system evaluation, because in implementation science, we evaluate the system to really adopt our tools. And this could help not us as a scientist only, but also the governments to see where we have the gaps and how we can deal with the gaps together.
If I may add, I think implementation science is surely very important, but I think your question is going even a little bit, because we always talk about co-creation, and co-creation means we develop a proposal, then we go to the government, we say, hi, that's what we would like to do. And do you agree, and give some comments and so on, then it goes for funding and we implement, which is not really, I think, co-creation. What we have done in Kenya in our latest project with the Kilifi government is from scratch involving the government, and one of the government people is co-PI on the program. So that helps a lot, because then they feel they learn about research. I'm not saying that every government official has to become a co-PI, absolutely not, but it changes the kind of the way people look at it. And my second reaction is that we as a research community, we have to learn, Salim said this morning as well, but to communicate better to other constituencies. I learned this when as an academic, I joined politics and I was a member of parliament. And I realized, of course I know this, but parliamentarians don't read the Lancet, and they shouldn't, because we should do better in bringing, kind of involving the constituencies from the beginning and bringing kind of the research and do our advocacy and our communication strategy requires more attention, I think, also within our EDCTP trainings. But you wanted to react?
Yes.
Oh, sorry, we have to divide. There is another question there, so maybe you can ask your question and we can see who can take it.
Thank you. My question is more of a challenge. I did not hear the place of mental health as a priority in the discussions, and I'm wondering where you're placing it, because it is a key problem. This is before and after delivery of children, and how they affect the health of the mother, postpartum depression. Thank you.
Somebody? No, I think we didn't have enough time to. Philippe, you wanted to react?
I think mental health was mentioned by Claudia a few moments ago. It's of course a very important part of the picture, and it has evidently to be integrated in the thinking, and as I mentioned in the inventory of what we are doing well and what needs to be done. And this is really an important part. Also, probably a sector where the input of the communities are the most important, because they are suffering from it. And they need to be voiced and give their advice on intervening on that.
I think mental health was mentioned, and it's getting much more attention than in the MDGs. In the MDGs, it was not on the agenda as well. Then going to the SDGs, adolescent mental health, NCDs has become much more a priority. Barbara, you want to?
And I wouldn't limit the issue of mental health to just the phase of pregnancy and delivery. I think the COVID pandemic, on the one hand, the impact of the pandemic, on the one hand, and the influence of digitalization on mental health in general has pushed mental health issues in general more at the forefront, including for further research to better understand the complexity and how to address it. So it's certainly valid for pregnant women, but I wouldn't limit the debate and the discussion on what type of, where the priority needs for research lie to that particular group, because adolescents and children are also.
Thank you. Now we go to that end. Yes, you have a question.
I'm Abdulhamid Babatunde from Nigeria. My question is about how do you think we can leverage on emerging technologies like blockchain, artificial intelligence, and Internet of Things in improving maternal care, especially in low and middle income countries? Thank you.
Somebody who wants to take that one?
No, I think it's real step that we need to adapt, and we had some experience of introducing studies that include digital technology, particularly using how can I say, a platform that can guide the health professional on diagnosis and reference to pregnant women that needs urgent care. And this worked very well to have a phone that the health professional introduce the signals and symptoms of the pregnant woman, and then the platform can help the health professional to diagnose and communicate with the reference health facility. This could be also used for reduce maternal mortality.
Yeah, and I think these new technology, including artificial intelligence, can help in different ways, either by helping the woman herself to get better understanding what is happening to her or better seek care. It can help the health professionals speed up the diagnosis. So there's a wealth of areas where these new technologies can make a difference. And I believe that under EDCTP already some projects are looking into that, maybe not specifically on maternal health issues, but I think that is where indeed these technologies could also help in alleviate the workload of the health workforce, so that they can concentrate their time on actual care as opposed to, for example, administration. So there's a wealth out there, but I then come back to the point of including women. I think when we talk notably on the use of artificial intelligence, it has to be trustworthy and it has to be validated as valid for both men and women and different ethnic groups, etc. So that is one of the challenges, I would say.
Thank you.
Thank you. Tom de Croo from the Institute of Tropical Medicine in Antwerp. I was interested about your remarks about TB during pregnancy. Preparing for this year's call, I looked at PubMed for number needed to screen to diagnose one active case, one person with active TB. Among pregnant women, it's quite high. Often it's about 500, even 1,000 women to be screened. So I wonder, how would you approach it? Would you use a lower threshold? Thus also maybe start TB treatment earlier, even if people would not have bacteriological confirmation of TB disease? Thank you.
Thank you. Thank you for this very interesting question. I think in TB control, and especially during pregnancy and postpartum, we really need paradigm shifting from case finding to a triage prospect of identifying by screening and having good screening tools, the people who need to be diagnosed with TB, and if possible, before the symptoms and signs and the devastating consequence of the disease are present. So I think this is the goal. We do not have those interesting tools for screening for the moment, especially in the context of a large number of people to be screened. But I think that this should remain the goal for further innovation. But I think we should not be complacent on this and use the tool we have for the moment. And the utmost priority is to identify women with active TB, and this can be done with the existing tools, and diagnose them, having them in the care system for TB, and prevent the consequence of TB in pregnancy.
Thank you, Philip. There is another question.
Thank you, Andrew Weeks from Liverpool. Maternal mortality is of course a disease of poverty, very clearly, and that it's a disease of poverty on the individual level. For individual women who are poor are far more likely to die, but it's also a disease of poverty when it comes to health systems. When health systems are poor, then death is more likely, but also infrastructure, country infrastructure. Now, the frustrating thing, of course, about maternal mortality, which I've been working in for many years, is that individual poverty and poverty of systems are so much more difficult to change. They don't take. There isn't a magic bullet that we can. We've kept thinking we can find a magic bullet. Is it misoprostol? Is it oxytocin? And of course, those things can help, but they're not. The overall thing is you need to lift people out of poverty. If you look back at maternal mortality for a century ago, it was exactly the same in the UK. And we didn't have a magic tweak that we didn't have oxytocin, but as soon as we got the systems right, maternal mortality plummeted. So really this is a core, I mean, we know what to do to reduce maternal mortality. It doesn't take anything clever. What we need to do is get on with implementation. And this is a core, and the question, I guess, is how exactly do we implement? How exactly do we get it right that we can use as little, we can gain as much bang for our buck as we can? So this is a call for implementation science. I think that's what we need to do in the global maternal mortality arena now. Thank you.
Thank you so much for that comment and that question. I think we couldn't agree more. And it's a disease of poverty or a situation of poverty. We need implementation science. But even if we have done the science and we know what to do, like we know what to do in maternal mortality, still it's not done because much more is important. Like Mahmoud Fatala always said, women don't die of diseases we cannot treat. They die because of the society has not decided that their lives are worth saving. And that was said 30 years ago, and it's still today, it's a priority. It's still a reality. And I think what the other, like health systems is not something sexy. You can get much more money for research and for programs, in vertical programs. We have to learn from HIV. HIV was successful. So what can, with PEPFAR and many, the changes are really real. So how could we use this model to also call for other maybe vertical programs, but HIV has also been very beneficial for the health systems, right? So if now we do for NCDs or we go for maternal mortality or other really striking inequities, how can we use the models that we know from HIV to get more attention, to get it higher on the political agenda? And that's what apparently we are not good in yet. But thanks for that comment. Any other questions on? I don't see anyone at the mic. Maybe last comments from the panel members before we close.
Thank you, Marlene. Being a woman and becoming from less developing country as Mozambique, I think my message to EDCTP is to avoid maternal death. All projects that are planned to avoid maternal health should be a priority to the EDCTP. I think with little that a group can do, it's a lot for African countries like Mozambique and for pregnant women from Mozambique.
Yes, I just want to come back to the last question. And I really think that what is co-substantial to this question is where we put the priority. And this is not a political question. This is a societal question. Where do we put the priority? And in my view, women's health and maternal health should be among the top priorities, and having the allocation of resources to tackle this as it deserved, since the consequence in terms of the society itself is so huge. So thank you again for this question, because I think it was a very, very important one.
Oh, sorry.
What I wanted to say is that EDCTP has done a great job so far and should continue to do so, and even more in relation notably on maternal and child health. But from the Commission perspective, is also I wanted to also pass the message that we work with our research funding instrument, but also with the colleagues that have the development cooperation instrument, and that is where we want to build the synergies, so that while you're discussing with governments about how and they would like to improve their health systems and what we can help them in doing so, that at the same time we make sure that evidence that comes from research feeds in that discussion. So I think that is important. And for example, now you know about the Team Europe initiative on vaccine manufacturing in Africa, and here also we see the importance of the work on conducting trials that will feed the products that the vaccines that will need to be manufactured. So I wanted to say that we keep an eye on the different instruments that we have and try to get more out of them.
Thank you, Barbara. And maybe a last word from my end, because here we are with a community of specialists in infectious diseases, right? We have also tackled a lot of other topics now with this panel. But coming back to the infectious diseases for pregnant women, HIV, not perfect yet, but we know how to screen, we know how to treat, etc. Syphilis, largely neglected. You know, we test pregnant women for syphilis in many programs. If they are lucky, the results get back before they deliver and they get treatment before they deliver. But still today, and I'm calling upon all of you, there is no treatment for a baby born out of a mom who is syphilis positive. It doesn't exist. It exists in paper, yes. 150,000 units of benzathine penicillin to a baby of 3 kilograms. Try to do it in your own hands. Take this sticky powder of 1.2 million and try to make the right solution. You can do it. So for 30 years, we are calling already upon maybe somebody here who is eager and willing to make a small solution for the baby, to treat the baby. And the same also, there is a renewed, and I'm happy that there is a renewed attention to gonorrhea and syphilis, right? We have all worked in the period of syndromic approach. It doesn't work, and surely not in pregnant women. But we see again that syphilis and chlamydia is going up, so with all the new technologies, should be possible to screen pregnant women also for STDs. Just You know, this is the core business, I think, of an EDCTP and infections. So I hope that some of you come with some innovative thinking and that we can also lower these important STIs in pregnant women. Having said that, I want to thank the panel members. Big clap. And our key presenter, of course, Dr. Hanson. We clapped already for her, but... and Lara Pandya, and everyone for listening to the panel and for all your great questions. Have a good evening and enjoy the rest of the conference. Thank you.
And thank you too, Marlene. And maybe just to highlight before everyone leaves, there are 2 sessions, special sessions after the break. Meet the researchers of PALIP in room 341 and meet the editors in room 342A. So please do go to check them. Oh, if you've registered. Thank you.